see everyone here. We're going to kick it off and work a whole minute past our start time. To make sure you're all in the right place, I'd like to give you guys a little way in, but this is the panel, Digital Health Role in Diverse Clinical Trials. For those of you who don't know me, I'm Izzy Ulmer from Becton Dickinson, or BD, on the regulatory policy team within Public Affairs. BD is a global medical device company, and we're extremely excited to partner with Avamed to lead this panel. At BD, we're committed to helping advance equitable health for all through our technical, innovation, partnerships, and investments in health system strengthening. Today, we're going to be joined by these distinguished experts on the stage with me, and it's amazing to see how many of people showed up and see the value in discussing tangible solutions to issues like under-enrollment in clinical trials, digital health technologies in evidence generation, and the digital divide. There's going to be a lot of great discussion, and to start with some takeaways that we hope you'll all have. These are session objectives, just high level. Our takeaway is we want you to be able to communicate the most common barriers to diverse population participation in clinical trials. Participants will be able to understand areas of opportunity with digital health technologies to engage new populations, and participants will be able to describe the necessary stakeholders in their roles to develop a diverse clinical trial. Underrepresentation of some ethnic and racial populations in clinical trials has long been recognized as an issue within the research community. Over the past several decades, we've seen an increasing focus on this from FDA, NIH, and various administrations. This is an extremely timely conversation now with the passage of recent legislation and release of guidances on enrollment of diverse populations in clinical trials from the FDA, which this panel will dive deeper into. According to a study in JAMA released in 2020, among approved drugs, participation of white patients in clinical trials was approximately 73.7%, while the 2020 census revealed the white alone non-Hispanic population represents only 57.8% of the U.S. On the devices side, in a study released in the November Quarterly that examined clinical trials for 22 PMA medical devices from 2014 to 2017, researchers found that for each pivotal trial, white patients made up 69 to 99% of patients. Clinical trial development has also faced an unprecedented burden over the last several years: how to continue research during the global pandemic. Many trials adapted to incorporate virtual care, including wearable digital health technologies, remote monitoring, telehealth, and other advancements. The pandemic forced researchers to think innovatively to continue to address trials and medical care, and much of this can be repurposed as an opportunity for assessing, accessing underrepresented populations outside of the pandemic, as we'll hear about from our panelists. With that, I'm excited to pass over to our moderator, Heather Colvin. Heather is the Director of Evidence and Outcome Policy for Johnson & Johnson MedTech, where she works to advance the adoption and global harmonization of innovative evidence approaches, including real-world evidence, improving the diversity in clinical evidence, and the science of patient input. Before J&J, Heather was the project director of the Biomedical Innovation and Evidence team at the Keith Margolis Center for Health Policy and the Brookings Institute. She also serves as a program officer at the National Academy of Sciences Institute of Medicine and an international health officer at the Department of Health and Human Services Office of Global Health Affairs. On a personal note, Heather is someone I've been very lucky to collaborate and learn from through Avamed, and I couldn't be more honored that she agreed to moderate this event. And with that, I'll pass it off to Heather to take things off.
So the very first thing I want to say is I was honored to be asked. And I just want to shout out to Izzy for really organizing this panel, pulling everyone together, and the collaboration that we see across the different stakeholders, different industry partnering with regulators and think tanks. So first off, thank you, Izzy. I am really excited to be here today because one is we have this incredible panel in front of us, and I feel very fortunate that I get to be the one to moderate the discussion. So let me do some quick introductions. So Michelle and I have known each other for a minute, And that's all I'll say on that. But we've had the opportunity to collaborate many times in various roles with each other. And she's currently the Deputy Center Director for Transformation. And that job doesn't tell you much, but there's a lot underneath it, the title. So she's responsible for facilitating the development, implementation, and direction of CDRH's transformation projects and initiatives. She is very focused, and when I say very focused, I mean laser focused, on really finding ways to address issues of the underserved and underrepresented populations, and that is inclusive of age, sex, gender, racial, and ethnic backgrounds. She's also very interested in rare diseases, individuals living with physical limitations, and also those in jurisdictions or areas with limited access, like rural regions. She has a pretty impressive academic background. She's no slacker. She has her bachelor's in biochemistry. She is a board-certified ophthalmologist. She also has a PhD in epidemiology, so she can explain all the hard terms to me. And the other thing is, if that job wasn't big enough, she also still actively sees patients in her ophthalmologic practice. And I found out last night that she is a budding opera singer. So if you weren't impressed enough, there you go. So the next individual is Calvin. So Calvin, he and I have not known each other, but I'm afraid he's stuck with me now. Because once you know a good person, you're going to stick with them. Calvin currently is serving as the Vice President of Medical and Scientific Affairs, North America at Becton Dickinson. He is responsible for the medical and scientific leadership throughout the external engagement, and he's going to be talking a lot about that. I'm very excited. With also focus on key healthcare systems, decision makers, and clinical thought leaders. He leads the clinical strategy and evidence generation needs of his teams, and his past roles include Chief Integration Officer and Chief of Infectious Diseases at Southern California's Kaiser Permanente, and Associate Professor of Infectious Disease and Global Public Health at NYU. He's currently serving, as can be expected, on several roles outside of the organization. He's been a member of the CDC's Antibiotic Utilization Work Group. He is a current governing committee member of the governing committee for NEST, the National Evaluation System for Healthcare Technologies, the public-private partnership established by FDA, and is also a fellow in Infectious Diseases Society since 2020. So he has a lot that he's pulling from his infectious disease background into his work at Becton Dickinson, and I'm hoping to hear a fair bit about that. And his medical degree comes from UCLA. He, fun fact, yeah, there we go, is a budding cartoon and comic book artist. And this is what we're thinking is going to be the retirement gig, right, Calvin?
Yep.
Yeah. Okay. And then last but not least is we have Yaseem. She joins us from Faster Cures, where she is the Deputy Center, looking at the wrong one. Director for Faster Cures Center of the Milken Institute. She's very focused, again, through all of her background, on health disparities, equity, health outcomes, clinical research, and in particular when it comes to stakeholder engagement across different groups and organizations. She has strong relationships with academic researchers, healthcare providers, and patient advocates. She has a lot of past roles. She's been doing a lot of work, and I'm not going to say what that means in terms of age, but you and I are probably about the same age. So she's been the co-director of health policy and fellowships at the National Academies of Medicine. She has been a program officer at PCORI, and she also has been directed global health and policy and tobacco control programs in the US, Asia, Middle East at the Johns Hopkins Bloomberg School of Public Health. She has a bachelor's in science in health services and management. And she also serves on a number of councils and committees and is a master's in sociology and women's health. So this is a pretty impressive crowd, but you're all pretty impressive as well. So this is going to be a panel discussion where you are expected to participate, and I will call you out if I know you. So do not be afraid, or if you have lots of questions, which I anticipate that you will, please come up to the microphones because we're going to be engaging with various conversations. So the first thing we're going to do is we're going to hand it off for some opening comments from our panelists. And Michelle, you're up first.
Excellent. So, thank you very much for the introduction. I've learned never to have a conversation with you about the things that I do in my off time. And so we'll proceed. So I'd like to share with you a little bit about the work that our center is doing to help advance health equity and leveraging the power that technology provides to do that. You probably have already heard about our strategic priority for 2022 through 2025, and it's really focused on ways that we can bring not only healthcare into the home or closer to the home for people living across this country, but also focused on ways in which we can better partner with patients in the clinical evidence enterprise. How can they be partners to help generate information that helps us better understand the performance of medical devices? And that means that all patients have an opportunity to participate. And how can technology help bridge that divide without widening it? Because we do need to be conscious of the other side of that conversation, because we truly believe that no person should be left behind in healthcare. So one way to start is by thinking about health equity across that total product life cycle of a medical device. Whether you're determining what your particular device is going to target in terms of conditions and focusing on conditions that are borne by certain segments of our population that don't have as many treatment options. When you're thinking about how that device is developed in a way that it fits within that population that's going to be using it, so that it's particularly ones that are going to be used in the home setting. How you design a clinical trial by partnering with patients as advisors that come from diverse backgrounds so that you can reach the communities that are often left out of the clinical trial process. And then when you think about the post-market surveillance efforts to ensure that the device continues to perform the way it was intended to perform in all the people that are designed to use it. Patients can be a powerful part of that process, and equity should be a powerful part of that consideration. So our strategic priority has 4 different prongs. The first and foremost is to empower people. We are committed to helping ensure that people can make informed decisions regarding their health care. To help facilitate the availability of and access to medical technologies that are available for all populations, to support innovation of technologies that address health disparities, and to reduce barriers and increase opportunities for participation by diverse populations in the evidence generation process. So how do we get there? Well, first off, it starts with making sure we're talking about the same thing and collecting the same information in the same way, so that we can make inferences and know that our conclusions are grounded in the same definitions. And the one way that we do that is through our guidance documents. That's the way that the FDA, as you know, issues our recommendations to the general public. One of the guidance documents speaks specifically about how one collects race and ethnicity data. And let's start first with understanding that race is a social-cultural construct. It is not biology. It is defined by laws, and it varies from state to state and country to country, and varies by reporter. So that's why this guidance is important. It first sets out that the reporter on race and ethnicity should be the person themselves, the patient themselves. Secondly, they should be offered an opportunity to respond on ethnicity, Hispanic or non-Hispanic. And then thirdly, present it with racial options and have the opportunity to click as many options as possible so that people can define themselves. Now, while it's not perfect, it is a way to do it consistently in all the trials that are done in the United States. It's not enough to just collect that information, though. It's also important that we analyze it and report it. And there are 2 guidances that the Center for Devices and Radiological Health have put out that speak specifically to how you do that for age, for sex, for race and ethnicity. This reporting is important because it helps us all to understand how the device performs in different groups, helps to identify opportunities for improvement for devices if they're not performing as well in certain groups, and then clearly communicates to the healthcare providers who are making informed decisions with their patients. One of the methods that we've used to help encourage innovation in this space is through our Breakthrough Device Program guidance update that was issued just a few weeks ago. And for those of you who may be aware, the Breakthrough Device Guidance Program is a voluntary program for certain medical devices and device-led combination products that allow for more effective treatment or diagnosis of life-threatening or irreversibly debilitating diseases or conditions. What's important about the update is that the update says that if your technology is helping to address health disparities or promote health equity, it can also be considered as a breakthrough device. So please consider that as you are developing technologies. There are also some draft guidances that we've put out that are designed to try to help advance health equity. The first is probably very familiar to many people in the audience. It's the diversity plan guidance that was issued last April. And that guidance spoke specifically about increasing race and ethnicity participation in clinical trials. And by being intentional and proactive, it may lead to greater representation in the trials that are conducted for drugs, devices, and biological products. Another guidance that came out that I put on this slide because I think it's important that we think about the technology itself and how it's developed. And this is the predetermined change control plans for artificial intelligence, machine learning, and AIML-enabled device and software function. This particular guidance speaks specifically about the importance of considering the training data sets and the validation studies that are done on these algorithms to ensure they reflect the population in which those technologies are going to be used. So consider health equity across the total product life cycle. Congress also issued an act at the end of 2022, which is FDORA, that spoke specifically about a commitment, a requirement that diversity action plans be collected and planned for clinical trials for drugs, devices, and biological products. Now, the importance of this particular act is that it's no longer a voluntary process. It will be required. And they have charged the agency with putting forth guidance on how to do that, and what would those plans look like, and what are our process for evaluating them. We're also going to be holding a public workshop to speak about how we can encourage the participation of different populations in trials. And that workshop is going to be held on November 29th through the 30th. I encourage you to register. It will cover all medical products, and will speak to not just race and ethnicity, because that is the provision in the diversity guidance that was draft, but Congress has said that we also need to consider age and sex in those plans as well. And so this workshop will talk about those different populations, including pregnant and lactating women, people with cognitive challenges, children, and racial and ethnic minorities. So I've spoken a lot about guidance documents, and there's one guidance document I didn't put on the slide, but it really does speak to the ways in which we can bring trials into the homes of people across the United States, and that's the Decentralized Clinical Trials Draft Guidance. And that guidance was issued in May of this year, and it specifically talks about how digital health technologies may be the way to help bring that input, bring trials closer to people who often can't get to trials, those who live in rural locations or have other factors that may impair their ability to come to a clinical site and spend 4 or 5 hours at that doctor's office. And that allows, the draft guidance speaks to the ability to do home visits with telemedicine. It speaks to the ability to do diagnostic testing at home, and how digital health technologies may help extend these options for patients. So it offers a lot of opportunities. In addition to the trials themselves, though, digital health technologies can potentially be an important way for us to, one, understand outcomes that may be collected in trials, so generate corroborating evidence about those particular outcomes, or propose novel endpoints that potentially can be used in trials. And so we are seeing an increasing number of studies, proposals, research efforts that are trying to find other ways to measure how people live and function in their daily lives without it being some of the standard outcomes that you may see in typical studies. And the last thing that I think it's important to emphasize is that, we're talking about trials, we're talking about evaluating medical products, but it's also to remember that people need care. We are increasingly seeing more and more hospitals close across this country. We're seeing healthcare providers starting to retire, and people are not replacing them. And so how are the people going to get the care that they need over their lifetime? And so we've got to be creative. We've got to rethink how we're doing healthcare. And digital health technologies may be one piece of that puzzle. We spoke about that during our Patient Engagement Advisory Committee meeting this past September about ways in which healthcare can come into the home. In particular, how can home use devices be used by the people that need them most? I encourage you to see the transcripts, the slides, and the presentations that came out during that discussion. And we're taking the feedback not only from this advisory committee meeting, but also from a docket that we had open, and we'll be moving forward with some recommendations. And as I said, we can't do any of this alone. It's really by collaborating with all of you all, everybody in the ecosystem, to discuss solutions together. It's not a one-size-fits-all. And I've listed on this slide a number of different collaborations that we partner with. And one that I want to highlight is the MedTech Color Collaborative Community. Anyone who was at the breakfast this morning probably heard about some of the work they're doing to identify clinical sites, providers, researchers of color that usually are seeing people of color, and that it's going to be important for us to extend those particular clinical trial networks to include those folks. There's also the Digital Health Measurement Collaborative Community, and they've been doing a lot of work at looking at sensor-based technologies and how they can help with health equity solutions. And so I encourage you to take a look at these collaborative community websites that are really partnering with others across the ecosystem to form solutions. I want to end with saying that it's important that we remember that we put all patients first means that it's all patients, that we can't leave anyone out of the healthcare enterprise. Otherwise, we will see these disparities widen. COVID was just a snapshot. It's not new. It's been happening for a very long time, and we're going to continue to see it widen unless we take intentional steps to close that divide. Our vision is that everyone in the United States has access to high quality, safe and effective medical devices of public health importance first in the world, and we are committed to doing that for all patients. Thank you.
So Yasmin is next. So, and then you, Calvin. So like Yasmin doesn't have slides, but you had some opening comments that you wanted to provide about your work in this space.
Yeah, so good morning, everyone. So I'm Yasmin Long. I am a director at Faster Cures. If you're not familiar with Faster Cures and the Milken Institute, we are a nonprofit, nonpartisan think tank. We focus on a number of issues, including the intersection of health and finance. I lead our health equity and diversity in clinical trials portfolio, where we're looking at achieving health equity across the biomedical research ecosystem using a multi-stakeholder approach. So what does that mean? That means all of the cooks in the kitchen, as I like to say, have to be a part of this effort, no longer being siloed and federal agencies here, researchers here. All of us have to come together to really achieve this for the long term. And so by a multi-stakeholder approach, what role do federal agencies have? What role does biopharma have? What role does patient advocacy organizations have? And then the role of digital technologies, community engagement, patient engagement, and so on and so forth. And so one of the things that we're focusing on specifically is the role of digital technologies and how that can accelerate treatments and therapeutics, particularly for patients that are experiencing the greatest disparities, and ensuring that when technologies are developed, that there's equity in mind. So an example of equity not being in mind is, I'm sure many of you have heard of the pulse oximeters that weren't reading dark skin tones. Well, is clearly a device that did not have equity in mind. So it has to be at the beginning. It has to be a forethought, not an afterthought, not when you realize the technology isn't working for certain groups or certain populations. So, and that's the point what Michelle was saying, being intentional, right? Another example is I have a colleague who, her grandmother, a very petite lady, had her knees replaced, knee replacement surgery, right? But the devices that they put in her knees were the size of like a 6 foot tall man. So she couldn't walk, okay? So you would think it would behoove us to have devices for all different sizes of people, right? So those are the kind of consequences that happen when technologies are not developed with equity in mind. And in some cases, it could be a life or death situation. So that's how critical this is for us to really partner together, collaborate, and really make change for the long term, because it has been happening for decades. We have the data, but we need better data, such as, and we're talking about race and ethnicity, and we think about those categories. I do applaud the OMB for trying to reorganize what those racial categories are. But when you think of the category of Black, for example, it's a huge diaspora of people. You think of a category of Asian, that's a huge diaspora of people, right? So if we're doing something that you're looking for genetic markers from someone might be from China and the other person is from Laos, and that they're marked as Asian, well, that could have different consequences on what that genetic makeup is, and therefore, have an effect on how a treatment and therapeutic is developed. So, and perhaps digital technologies can be used to help sort of disaggregate or aggregate that type of data, for example. And then lastly, I'll say, healthcare is a civil right. If you don't have a job, then you might not have access to health insurance. If you don't have health insurance, you probably are not accessing a clinical trial. And what if that clinical trial is the only means you have as a treatment for whatever condition that you have? So, we're kind of thinking about it in that way, putting the empathy back. And I always say, show up as a human first. So I'll pause there.
Thank you. So I just wanted to start by saying that Calvin is going to be pulling this all together in terms of, like, from the industry perspective, how do we implement and kind of move the needle there?
Yeah, thank you, Michelle and Yasmin. So I'm going to index on elements of both of those talks on research that can be done now, speaking of the digital age. So I was in some of the meetings earlier, and digital health has become a grab bag statement for anything from AI-generated insights to help the clinician, to something as simple as, and this shows my age, putting paper charts into a digital format. And so I want to show and share with you on how we can identify vulnerable patients and 3 specific clinical use cases and how that can inform clinical trials. So for a vulnerable patient, that can mean different things. So patients who are disproportionately affected by the disease, but especially disproportionately experiencing higher morbidity and mortality outcomes. And it's not like this is a new concept. With HIV as an epidemic, hepatitis C, we saw disproportionately worse outcomes in people of color, low socioeconomic groups. And they were labeled as non-compliant, and I'll get into that a little bit later. But it's not just that. Difficulty accessing medical care can occur to any person that doesn't have access, and then not having a voice in healthcare. So pediatrics is a popular segment where my peds colleagues are always saying that they are misrepresented or not represented at all in clinical trials. And so I want to show you 3 use cases of common clinical entities where if you just scratch at the surface, you have some insights, but if you dig a little bit deeper, and this is available through electronic medical records, all of these are original studies that we've published through BD in collaboration with other industry and public health entities like the CDC on showing how we can delineate these vulnerable populations. So first, just context setting. So for UTIs, which happens, as you know, in young and elderly females alike, the current guidelines for your 3 drugs of first or second line therapies for UTI have been the same for the last 2 decades. And I'm being generous, it's actually been almost 3 decades. And so we did a simple study represented at the bar graph on the top of those 3 drugs and the resistance to E. coli, which is the #1 pathogen to UTIs. And so you have Bactrim, which I think everyone's familiar with, 30% resistance to E. coli. And if you're a clinician, we go by the 80-20 rule. If you're using a drug to treat a bug, it should be no more than 20% resistance. Otherwise, the risk-benefit ratio just isn't worth it. Fluoroquinolones like Cipro, more than 20% resistance. Nitrofurantoin is hanging in there. It's one of the oldest drugs at around 4%. But if you look at 2-drug and 3-drug resistance, those are actually climbing. And so we're in a situation where the recommended guidelines from my own society, the Infectious Disease Society of America, is championing the same 3 drugs that are not potentially efficacious. So we dug a level deeper by these heat maps in the US, and we said, okay, let's heat map individual resistance. And so those are the 2 US maps at the top. Brown is more resistance, And then we looked at 2-drug and 3-drug resistance, and again, brown is the worst. And so there are definitely areas where you may have a simple UTI, your daughter, your grandmother, your wife, and they might not have any option for an efficacious therapy. And so this study basically showed, two of them combined, suggests that the current UTI guidelines are not adequate because antimicrobial resistance is increasing in the antibiotics championed by the society guidelines to treat UTIs. There's more and increasing 2-drug and 3-drug resistance, which means you're not going to get a therapeutic antimicrobial in those cases. But more importantly, geography matters. And so most studies would stop at the first study where it just shows resistance problems and there. But in this day and age, when we need to find out what the vulnerable populations are, going down to that heat map level, collaborating with the CDC on their SVI index was extremely important because what we found out was that if you're a patient that lives in a high resistance area, you're most likely going to get an ineffective antibiotic for just a simple UTI, which you would not think is the case for something so common. The highest antimicrobial resistant zip codes coincided with higher density people of color and lower socioeconomic income populations. And so this begs the question, well, what type of access to healthcare do these people actually have? But more importantly, even if they have access to healthcare, they're living in areas where their first therapy for a common UTI, or even a second one if that fails, probably has a high likelihood of not working. And so you get into the root of the matter. These populations have had bad experiences with the medical system in general. So I'm referencing the Tuskegee experiments for African Americans. What is this going to do with the trust with healthcare if you're going for a simple UTI and it fails, the second one fails, or you might not even have a viable option? And so these are the things that frontline clinicians face, and yet there's the guidelines are still the same as they were 20 years ago. So the second example of 3 is another common entity, community-acquired pneumonia, and the most common cause is strep pneumonia for adults and kids. So we did something similar. I reminded you of the 80-20 rule. If you're going to treat a bug, you should have at least no more than 20% resistance. And so we heat mapped resistant Streptococcus pneumoniae to azithromycin macrolides, so that's one of the classes that's recommended as first-line therapy. And so again, the more orange the area, the higher the resistance rate, and it goes up all the way to greater than 50%. And so when we heat mapped the macrolide resistance of strep pneumonia, there's obviously areas, and if you look at the CDC, sort of the way they partition the US, they do it by quadrants. Each of those areas actually have a high resistance. In fact, that journal that published that paper had an editorial by one of the authors of the new pneumonia guidelines, which took 17 years to update. And this was only within, not even a year had passed since they updated it. And he wrote, the results of this study shows that the rate of macrolide resistance against strep pneumonia is greater than 25% in all areas of the country. Taken together, these considerations should lead us to question recommendations of the ATS-IDSA guidelines for the management of pneumonia. He was an author of that, and this was not even a year out. And so this is the power of real-world evidence, but also a highlight of how we can collaborate. This was industry, academics, and ultimately the CDC has been involved in this, where they looked at the SVI index, and it turns out that Streptococcus pneumonia antibiotic resistance was highly correlated with socioeconomic status, household composition like single parenthood, and or disability. And so when we talk about vulnerable patient populations, we have to keep in mind it's not just people of color, it's not just kids, are the people that are disadvantaged in different ways. And then in the meantime, the one good news is the IDSA is revamping their guidelines. They're not waiting another 17 years. They're going to revamp it, I think, in the next 2 years. In the meantime, we published a follow-up paper and showed that children, another disadvantaged group, you could say, or vulnerable population, the resistance rate is 40%. It's the 80-20 rule, not the 80-40 rule. And so a lot of kids are getting antibiotics that for pneumonias, which may not even work. And so this is a serious public health issue, and this is a good example where real-world evidence identifies the clinical gaps, can also identify what vulnerable populations mean for that clinical disease state, and that this is information that these demographics should be included in prospective clinical trials. So real-world evidence is getting a lot of spotlight these days. I want to make it clear, it is an adjunct to prospective clinical trials. It can help inform what your criteria and demographics are for the relevant populations that have disproportionately deleterious clinical outcomes, but it's not a replacement for it. But there's definitely a place for RWE. The third use case, disease state, is cancer patients with drug resistance. And so this slide is a little busy, but basically the higher the bar, the more drug resistance. The orange are cancer patients, the blue are similar patients without the cancer. And so any way you slice the data, what we basically have shown is that cancer patients have a twofold increase in drug resistance when they're infected in the bloodstream, which can evolve into sepsis, especially when you have no immune system to fight off the infection. And so we know that these situations cause higher length of stay, cost, treatment durations, all the things that C-suite and healthcare systems don't like because it ruins their bottom line. And so oncology patients are often excluded from new antibiotic clinical trials, and yet they have 2 times the higher risk of resistant organisms in the life-threatening bloodstream infections. So it makes you think on, we have to change the way that we construct the clinical trials to include the populations that are actually having the most deleterious outcomes. The other thing I want to say about cancer patients is what we learned from the pandemic is that a lot of healthcare systems are proactively and out of fiscal need moving the therapy for oncology patients to non-acute care centers. And this might be one of those cases where real-world evidence helps inform that. The question still remains, why do they have higher drug resistance? Is it because we're constantly bringing them back in the acute care center where MRSA, VRE, ESBL are on the environment and higher density in general? Or is it because we keep on giving them antibiotics every time they sneeze and have a sniffle? It could be both, but this movement that healthcare systems are doing is a real phenomenon, and this is where MedTech can sort of meet the challenge here. If they're intent on doing, mop-up chemotherapy at home or in an outpatient infusion center, then we have to innovate to enable that to be done safely. And even having diagnostics and ability to draw your blood instead of going to a tertiary center where you expose yourself to Candida auris or MRSA, why not have it done at the home? And so this movement towards home care, I think it's upon MedTech to sort of enable that in a safe and powerful way. So in summary, real-world evidence can identify vulnerable populations. It can mean different things for different disease states. It can inform the important prospective clinical trials on criteria of enrollment so that we make sure we include, to Michelle and Yasmin's point, that we include the patients that have the disproportionate deleterious outcomes right off the bat. Tools to facilitate participation. So I know I pointed out that people of color, low socioeconomic income, children, those are notoriously taught to us in medical school as people that are not compliant. But you really have to look at the reason why. A lot of my experience at Kaiser was people were not coming to appointments or picking up their medications because they had to choose between paying for a cab to see me or the medications and feeding their kids. And I will tell you, every single time, they will choose their kids over seeing me or filling out a prescription. And so one of the more successful programs at that healthcare system in my prior life was giving taxi or Lyft vouchers for those patients that have self-identified. There was another initiative in San Diego County looking at homeless follow-up at FQHC clinics, and it turns out 50% of the homeless that they were tracking actually had cell phones. So that opened up the door to digital health technology, telehealth, and follow-ups, and so they were able to get more traction on follow-ups through the fact that they had cell phones. And finally, the trust issue through the Tuskegee experiments and more recent examples is a very real phenomenon. And so one of the more successful ways of getting a higher uptick in flu vaccinations was to rely on faith-based leaders, sponsorship, and going out in the community and making the effort to build that trust back. And also sports stars are always a good thing for any demographic. And so those are just some ideas through my past life that have worked to help. And I hope we, as a community of medtech industry, index on those so that we can get those patients that have the bad outcomes into the prospective clinical trials. And last but not least, we know the federal government is sort of championing real-world evidence and diversity and inclusion. My pitch to you through this data is that they don't have to be mutually exclusive. So this is a little bit of a plug for the MDIC NEST consortium, where it's our job to use real-world evidence to help extend FDA claims for medtech, but not just to do that, but more importantly, to enable those patients that need access to the devices, the analytics, the diagnostics, so that we can take better care of them and show up differently. So with that, I think I'll end my portion of this.
So we have reserved a lot of time for the panel discussion, but also for the audience. So we're going to start off with a question to the audience, because this is a classroom, right, or is going to be. So how many of you have actually ever been a patient in a clinical study? By a show of hands. Anybody? See, 1, 2, 3, 4, 5, 6, 7. Well, bassoon, of course. So we have a few people in the room, a very small percentage of the people in the room, who've actually been a patient in a clinical trial, a clinical study. How many of you would like to be? How many of you would like to engage in clinical research? Show of hands. Any? It's not as many people as I thought. For those who have not participated but would like to, why? So Izzy, you're in the front. Can you go to the, why haven't you before?
So I actually looked into if I could participate in a clinical trial recently, and I couldn't find one that I qualified for. So,
Okay. Anyone else willing to offer up an answer about why they haven't but would be willing to?
I have one.
Okay,
Just
go for it.
the reason I haven't participated in a clinical trial is because I've never been asked, ever.
Ding, 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 ding. So I think that that's a big part of it, is you have to be asked. Because how are you going to know? Because you looked actively wanting to participate. But that's not how patients get into clinical trials. They are generally referred by their doctors because they are appropriate or could be appropriate for a clinical study. And I tried to be a healthy patient for Alzheimer's studies. And I can tell you that every time they tried to set up a meeting with me and the doctors, it was always at Wednesday at NIH between 10 and 12 p.m. during the workday, or some other inconvenient hour, and they were inflexible in their time and schedule. So even those of us who would like to participate and who are actively doing it or have never been asked, like, it is not convenient. And I have a car. I can pay for transportation. I can pay for parking. I can do all of that. Imagine what it would be like if you were someone who had been referred by your doctor or was appropriate for the clinical trial. But to your point, Calvin, like, life decisions have to be made. We have one clinical site where it costs $90 to pay for parking for one day. $90. I would cringe at that. Anybody else would as well. So I just want to think about like how we're engaging and thinking about the real obstacles. It's not that patients aren't compliant. It's that we make studies that are hard to participate in, or we don't even invite them in the first place. So that's the first kind of thought out there. But the other thing I wanted to open up with, this is about digital tools. Like, this is what we're talking about, is this is one of the many ways that we could expand the clinical research community. And I feel like we have this technology fetish. Every time there's a technical tool, we're like, that would be awesome. We'll just fix it with this widget. But I'd like to talk a little bit more and have each of the panelists talk about how the technology by itself isn't sufficient, that we need to get to some of the issues of trust, some of the issues of access, some of the issues of how do they get into the system. So I'm going to start with Yasmin and talk about the marriage of the technology and the culture around clinical trials.
So, kind of when I think about trust, right, there could be folks who might not want to enter a certain status, maybe whether they're undocumented, for example, or they might feel that they're being tracked somehow. That's an issue of mistrust, right? As an example. When we think about Tuskegee, depending on when you were born, some folks might not know what that means, right? Many of us in the research world do, but again, depending on when you were born. But the thing about that study, it's the short name is Tuskegee, but it is the United States Public Health Service study of syphilis in the Negro male. United States Public Health Service. They conducted that study for 20 years. The United States government did that, okay? That's what that study is. That is horrifying, okay, for anyone who would even touch research, right? So that's a historical, point. But then there's also ways of, just getting how you're treated in the doctor's office. For example, you walk in, they might not even say good morning to you, or they just hand you a pen, here, sign, no, acknowledging you as a person, a good morning or how are you? It's very simple to do. But those are the kinds of things that happen to folks, whereas another person who walks in right behind them, who might look different, might get a good morning and how are you, how was your day? So, or your pain is denied, or you're given a treatment that you didn't ask for, but it seems like, oh, you probably need it because you're this. Those are things that happen currently. Now, I have had high quality healthcare my whole life, but that does not mean I haven't experienced any type of inequities, okay? So we're thinking about this, again, across the ecosystem in ways. Some of that is behavioral. Some of that is everybody has biases, no matter what your race or ethnicity is. And that can be biases with, someone who looks at you as well. So that has to be acknowledged and checked at the door, particularly on the clinician side, right? So there's a number of different factors. One of the things that we focus on in the work that I do at Faster Cures is providing, providing actionable recommendations, action steps. There's a lot of talk, let's talk about it. I always say, let's not talk about it, let's be about it. So we focus on what are actionable steps that stakeholders can do, federal agencies, medical device companies, again, patient advocates, for example. What are the actionable steps that can be taken and implemented for long-term and short-term change? I think that's where we are at this point. That's where we have to be at this point. Enough talk, let's do this, right? So, but easier said than done. But, I think as a collective, we have the expertise and experience to be able to provide that type of guidance, because those that want to participate in equity or design a device with equity in mind may not know how to think of it. But if you collaborate with others and bring that thought leadership together, that is a mechanism for change, I think. I'll leave it there.
And Michelle, thinking about how the agency is looking at that technology, implementing technology, the decentralized clinical trials, for instance, have they thought about the concerns around the trust and the technology, and that's not going to fix it all kind of solution?
I think you bring up a really good point that trust is not something we can assume. I mean, you mentioned Tuskegee, but there's been a lot. That's not the only violation of trust for many patient communities. And so when you've got that deep history related to the research enterprise, we have to intentionally, proactively, in a sustainable way, create partnerships with communities and bring them into the device development phase, figuring out what do they expect from the device? How do they want it to integrate into their life, and how does it fit into their life? And then how is it going to improve their outcomes? Oftentimes things are designed for patients and then plopped in their lap, and there's an expected uptake. And that doesn't happen for all communities unless you talk with them in advance. So I think as we're thinking about digital health technologies, one, they should be not something that is stigmatizing or identifying, so patient privacy can be maintained. I think it's important to partner with patients to understand how will it fit within their daily lies. If it's something they have to wear on their wrist and all day long they have their hands immersed in water, that may not be a good technology for them in terms of managing their healthcare. So having those important conversations in the design phase. And then when we talk about trials, how do we bring them in? You know, we talked a little bit about this yesterday during one of the workshop yesterday afternoon about patient engagement, but it really is about relationships. When we think about everything as transactional, when you already have fractured trust, transactional exchanges then further compromise that trust. And so creating partnerships that are sustained, that are, we care about you, there's reciprocity here. I think that helps to build bridges and brings patients who are often left out of clinical trials and post-market study efforts, brings them into the enterprise and makes them feel like a valued and respected partner. And I think the last thing, as we're thinking about these technologies, and as I mentioned in my presentation, is being intentional at every step. Thinking about, is what I'm developing going to make things worse for the population I'm trying to help or better? And being thoughtful in that process can help prevent some of the unanticipated or unintended consequences.
That's a great point. And I think one of the things that you brought up, Calvin, that really resonated is you talked about kind of the different populations. And I'm thinking about the digital divide discussions, you know, the issues that, you know, even if you live in a large urban area, that does not mean you have access to broadband and can do a telemedicine visit, or that you can afford the data on your phone. Have you thought about in your clinical trial work, like how to bridge that digital divide, and what obstacles have you come up against to include people from different socioeconomic backgrounds or even regional differences, rural to urban?
Yeah, I mean, two things come to mind. One is for those that do have the digital option, just the low-hanging fruit, translating it into different languages automatically. I mean, it sounds so simple, but it really does shift the optic from I'm other and I'm not the target of this clinical trial to, oh, they thought about me, I might think about it. So that's one. The other is, you know, I know I mentioned this, but we shouldn't underestimate community-based sponsors, like certain faith-based organizations that can get on board with whatever clinical disease state, because they're aware of the disproportionate outcomes that their communities have. And so, you know, when I worked at Kaiser and actually at NYU, when I was getting my public health degree, both of them had different iterations of reaching out to community centers and just getting a buy-in so they can put flyers there, or they can give information there and have a sponsor in terms of, not a paid sponsor, but a speaker that could represent sort of their demographics viewpoint. And so that, you know, that's not a panacea, but it actually moves the dial. And I think we could do more like that.
I think that the translation is never underestimated. Like the number of times we've done some internal looking and looked at other research studies, and the number of studies with the patient information translated is not what it should be.
Right.
And if it is, it's typically only to Spanish.
Right.
So there is that the language is incredibly important. I'm going to put you a little on the spot.
Okay.
And I'm looking at Michelle here, but I'll come up to you later. So I was, the timeline for the new diversity plan guidance document is fast approaching. And I think one of the things that we saw, and we had lots of questions about, there's a two-pronged question, is one is the concern that they were going to try to use the same approach in medical devices or in med tech that they would use in a large drug or biologic study, because very different types of clinical studies, different types of clinical research. I would love to hear how the agency is looking at the differences of different types of trials. And I know it's all in draft right now, but is that something that, like, I know you're participating in those conversations. Could you say a little bit more about how you're looking at med tech versus what might be expected in like the larger clinical drug studies?
So for the medical device industry, in the congressional language, it mentions pretty much everything, right?
Yes.
For drugs, it says phase 3 studies. For devices, it says 510K, HDEs, de novos, PMAs, IDEs. So pretty much everything. And so what we are doing is taking a very careful look at what does that mean for our industry and what the drug provisions may look like. They may not be identical for devices, and we are actively writing a section in the guidance that will apply to devices. So yes, we are being thoughtful and intentional in thinking about that. But we also want to make sure that we encourage diversity in our clinical trials. And we have, you've heard some allusions to some of the devices that are not performing as intended once they were enrolled with use. So how can we prevent further instances of that? And we mentioned at the Patient Engagement Advisory Committee how we're looking at a framework for when it really is necessary for us to have certain types of patients as part of our clinical studies, and why, and what would be the reason for why we would really need it, and to make an informed regulatory decision. So that's another consideration that we are doing. Our timeline is fast approaching, and I will say
No pressure, no pressure.
I will say that, part of what we're also doing is bringing in input from the entire community, which is why that workshop is happening in November, so that we can hear what are the challenges that people have experienced, what are the success stories too, what's worked, and so can we mimic that across the sector, and hopefully we will hear some of those examples that others can learn as this draft guidance moves forward towards the end of this year.
And one of the other questions that we've had is this adds a whole nother layer of complexity to any type of review by the agency. And could you speak a little bit about kind of the capacity building within the agency to kind of address that and bringing in the expertise or training your teams? Again, putting you on the spot. We're all waited with bated breath here.
I'm getting used to that from you, Heather. I will say that, when the legislation was passed at the end of last year, we started working immediately, figuring out what are we going to need in terms of expertise? What are we going to be reviewing? What's the process to even accept them? As you may know, that part of the provision of that act, there is a waiver provision. Yeah. Very, very small justification for when a waiver would be accepted. But how are we going to receive those? How are we going to evaluate that? And so we are actively working within each of our medical product centers and then sharing amongst the medical product centers the approaches that we're thinking of how to implement that. So yes. Yes to your answer. Yes, we're planning. Yes, we're building up, and we're building the capacity and the expertise and the resources that teams will need to actually review that type of information. We also hope to help the industry by putting some things out public that we're developing so that we all can learn together. I think this is a collaborative effort. It is not a one-sided push it over the fence type of thing. It's where we can all work together because we all benefit from well-conducted studies that reflect the patients that we are hoping to see good healthcare outcomes with.
And so, Yasmin, Calvin, what would you love to see in the guidance document if you were king for the day or the head of the FDA?
I'd like to see, this is going to sound very controversial, but I'd like to see something in there that says, if you don't complete this, you don't get funding. People, when you take money away, people start moving. Okay, so now that might, that's not a terminology that could actually go in there, but sort of if your diversity action plan isn't up to par as it should be, and now you have guidance, you've done this, then your application isn't approved, or which could shut down your funding, for example. Yeah, that.
Calvin?
I have a different version of this.
That was a little harsh.
So there's a lot of real-world evidence on different populations. So I'll do a non-infectious disease one. So peripheral vascular disease preferentially affects people of color, obese, low socioeconomic income folks. And if you're a med tech company that makes intravascular devices, whether it's a Roto-Rooter type of thing that unclogs arteries, the phenotype of the vasculature is quite different. You were speaking about different races having different sort of genetic markers, but it's the same as your phenotype and your actual physical build. And so if we had information, peer-reviewed information that showed, a large percentage of people with peripheral vascular disease are of certain ethnicities or a certain BMI, then it might be a requirement that when you're doing new product development and applying for 510(k) or whatever, that you include a certain percentage of those so that they're represented. And it helps the company because you want to sell the product, right? And so you want to be applicable to as many people as possible. Mm-hmm. So that's one of those areas where I think collaboration could be a win-win, where everyone's getting what they want out of this, but most of all, the patient.
Yeah. So I am going to ask you all for questions, and if people don't start asking questions, I'm going to start asking you, so be warned. Oh, Bill, I see one. Others, if you want, come on up to the mics, please.
I had to be proactive here because I knew you'd ultimately get to me.
I would get to you, yeah.
Yes.
Vassoon, you're up next.
Yeah. So I'm going to be a little provocative here. So the example pulse oximetry came up. I was at a Fidley conference, a similar topic earlier this year. And the question came up, if a study was done with a broad population and the results came back and it showed this difference in effect, how will you deal with it? Is it done with labeling, or is the product not approved? And so how do we think about that where products may not be appropriate for all populations? Because, of course, when clinical trials are designed, they're usually designed to maximize effect size. And so there's this tension of trying to increase the probability of successful outcomes, right? And expanding the diversity of inclusion and figuring out how to balance that. So it's an interesting, I think, conundrum that is going to be coming up in terms of the regulators at some point in time.
You mentioned, should it be approved? No.
So, and that's interesting because the regulator that was on that panel said you deal with it with the labeling. So
And who does that help?
Well,
I mean,
a subset of the population, right?
Yeah,
Yep.
and that's fine if that's the outcomes that they want. But I would imagine that it's, not approved, go back to the drawing board, start over, and, make it more applicable to
Right.
all.
Yep.
And I would imagine that would also be a positive thing for return on investment, right? We're thinking
Yep.
about that. So that would be my recommendation.
I think also, just having that sort of black box warning or sort of caveat
Yeah.
will inspire competition because there's new technology. So there's laser light
Right.
refraction that doesn't is not hindered by pigmentation.
Right.
So non-invasive technology that can also measure oxygenation.
There's a spur for innovation based on the discovery that comes out of that. I
Correct.
agree completely.
Correct.
And the other one was access, when they talked about like large multi-million-dollar new technologies come out aren't going to be available in all healthcare institutions immediately because of just the economics and the financial aspects of that. So anyway, it's a complex question. I just thought I would start with a provocative one.
Yeah. I'm also feeling that she's bad cop and I'm good cop.
And I'll be neutral cop. So I think it's a really good question, right? How do you weigh the benefits of helping an innovative product get to market quickly, but also ensure that it will work and all the people that you want it to work for? Sometimes the exclusion may actually hurt you in the back end, right? Where there may be untoward events that happen in certain groups, and then you're facing the reality of what that will look like for the company, potentially, if it wasn't studied in those groups but used in those groups. I think the other challenge, though, is we all benefit from learning when we include all patients in the clinical trial enterprise. There are things that we may be surprised that it actually works better in certain populations. If we had included them, we may have increased our market for those patient populations. So I think I think we should be thinking about it, what is the value add? And the value add is by including people, we learn more about our technology. We may potentially increase our marketplace, and it also may help us prevent from doing harms and lead to new improvement and iterative pathways. So
The lack of education gets to a point of potentially not realizing that you have a limitation. So actually knowing that there's a limitation helps improve the care.
absolutely.
And I don't know, I'm neutral cop too. So I see this as an opportunity to get to more personalized medicine, like this idea that one size fits all, that if the device can only be approved if it fits everybody, is actually not the way we should be going. If we have important clinical insights that come out from that study that show that it is better suited to one population than another, I agree that that's something you address in the labeling. Because why would you deny access to that product to one patient population because it didn't fit this other patient population? So that's my 3 cents. So go ahead.
Sure. Hi, everybody. Well, Hi, Michelle. Hi, Calvin. Hello. Juan Espinoza, Lurie Children's Hospital and CTIP. I was actually going to make a different comment, but just because he mentioned pulse ox, I do think it's worth noting, and potentially, if you would like to or not respond to it, is the fact that the first paper published on that showed evidence that pulse oximetry as the current generation of pulse oximeters was less sensitive and specific in individuals with darker skin tones was published in 2005. We did not have congressional hearings about that until 2021. So what do we do with that evidence? But that's actually not my question. But I think it's worth for everybody to know that, like, we've known that this is a problem for 15 years and nobody cared until it was in the news. And so we need to do a better job as an industry, as government agencies, of how do we identify these signals and actually care in a timely fashion. Because a lot of those deaths in Black and brown communities related to the lack of sensitivity, we knew that problem in 2005. So that actually wasn't my comment. It's always worth repeating because a lot of people don't know that we knew. And so it's worth knowing that this is a failure at a larger scale than just how these devices were approved in the first place.
Actually, if I may, I think that's a really important point. By the way, we knew each other. So,
Yeah.
we knew this in the 1980s with HIV, with disproportionate outcomes in people of color, Latinos, in America at least. We then, in the next 2 decades, learned that about hepatitis C. And then COVID hit, and now it's been, epidemiologists and infectious disease doctors could have told you when COVID was hitting big that people of color, low socioeconomic incomes would suffer greatly. And so does it take a worldwide pandemic for us to pay attention to the evidence? Hopefully the answer is yes, but if we don't, we're at an inflection point where we have to do something about it now in a collaboration between industry, public health, and the government. Otherwise, I can't think of anything bigger than a worldwide pandemic. But anyway, good point.
And hopefully we won't have another one anytime soon.
For a little while.
Yes. So we have 5, I'm getting the 5-minute warning from Izzy. So I have 2 questions.
Yes.
So
So I'll be quick. So listening, this is more of a comment that hopefully spurs some conversation or some thought, is hearing about like everything that we've discussed today, which everything is true and reflects my experience as well. But it also reminds me of the huge chasm between the approach to adult medicine and the approach to pediatric medicine. Many of the issues that have been discussed here, we've actually been addressing in pediatrics for 30 to 40 years, right? Pediatric trials, pediatric medicine is foundationally a holistic approach. We think about the entire patient. It is the child and their parents and their school and their teachers and their siblings. And that has informed the way that we at least investigator-initiated trials are designed and carried out. And so you have that perspective. And the other perspective is that because by and large, from a real dollars perspective, both industry and the government have more or less neglected pediatrics, we've been forced to do more with less. And still have a more diverse workforce and still have a more diverse patient population and better addressing disparities in our population. So I think there's a lot that industry and adult medicine can learn from the way that we do things in pediatrics. We don't do everything well. There's lots of failures, biases everywhere. But I think that the approach has been really ironed out in a lot of ways in pediatrics. And so pediatrics, we're a big tent people. Come join us. Come hang out.
this is his recruiting speech. He does it. This is the second time.
And
I've
let
heard
us
it. So please
help
join.
you. So anyway, that was my comment.
Okay,
Other
great.
people.
Thank you. Last
Hi,
question.
yes. Thanks. My question is regarding access to clinical trials and to healthcare, and being a full-time independent consultant with this spinal cord injury and multiple secondary complications. I'm thinking about the disability population in the United States as it relates to access to equity in healthcare. One challenge we're really running into around the country is with Obamacare, whether you're on Medicare, Medicaid, or the marketplace, and not discriminating against pre-existing conditions. A big challenge is a lot of people that I know want to have access to clinical trials. However, we're going backwards in our U.S. healthcare system with respect to these healthcare marketplaces are shrinking and shrinking and shrinking. So they're not discriminating against us, but I live in North Carolina, and my doctors are shrinking. So I can't even see the specialists that I need for different clinical trials and different medical technology products. And so that's a real challenge that I think in the MedTech conference from patient perspective that we're running into is so many individuals, they can't even see the right doctors and specialists they need to have access to healthcare equity and inclusion. And so I wanted to get your thoughts on that because many patients, they just don't know because they're not seeing the right doctors.
So I would love to pipe in, if that's okay, a moderator's prerogative. And one of the things that I really love about the omnibus is it actually expands the populations of interest in the diversity plan guidance document. And it expands it to broader populations, including people with physical disabilities and also rural areas where they may not have access. So I think that that's one of the things that we're trying to think through, but it is a systematic challenge that we have to think, and Dr. Califf has said multiple times, that our clinical trial infrastructure is built on top of our healthcare infrastructure, and all of the fractures and issues that we see in the clinical trial are directly related to our healthcare infrastructure. So that's my broader plea for like better health equity more broadly, but it is a challenge and it is something we're gonna have to think through, like how to reach harder to get populations or populations with limited access to healthcare options.
Well, and that comes down to coalition building with medical technology conferences and patient advocacy. But a big challenge with patient advocacy organizations is they want access to so many folks in this room, but there's so many barriers to entry and frictions on how to partner together. So that's why I'm here today.
Well, there's this great organization, MedTech Color, so we should connect on that one because
Absolutely.
I think the idea with that is that, I'm going to steal your thunder on that, or you should still talk about MedTech Color, the collaborative community. Well, there are like these collaborative communities that are intended to be these test beds, these sandboxes. And so I think that that's one of the places where the patient communities could be more engaged in that, because right now it's academics, it's regulators, and it's industry, but we definitely would want to have more patients engaged with like the collaborative community at MedTech Color, for instance.
No, I think you bring up a good point, which is there's a lot of groups that have not had solutions or abilities to participate in clinical trials just based on what you've just alluded to. And I think it's one of the undergirdings behind the strategic priority that we've been talking about at CDRH, which is how do we bring it to the home or closer to the home so that people who have a hard time getting to the healthcare system can actually be part of the clinical trial process. Technology is one way that we can do that, but also rethinking how we actually do clinical trials. That's why I alluded to the draft decentralized clinical trial guidance. It's another way that we say, okay, here are some ways that we can move it out of a centralized location and distribute it into the communities that really need to be a part of contributing evidence to how we understand the performance of medical products in general. So I think your point's very well taken, and partnering with patients to figure out the best ways to do that, I think, is also important.
We have 3 minutes left. And so I'm going to end this on kind of an inspirational note. Like I would like to end it on an inspirational note. So I'm going to go quick 5, like second challenge for each of you. You know, what do you hope to get out of this? Why did you get into this in the first place, this field? Why is this an area of interest? And what do you hope the next big step is? So, Yasmin?
Well, I've always been interested in health and science since I was a child. So this is what I do, right, in terms of just career-wise and expertise. And I just always, I was like a little baby nurse. I don't know how to explain it, but like, I was always caretaking family members, and that's just how I was, right? And so that turned into, well, my family wanted me to go to medical school and be a surgeon, but outside of that, which is a very fine profession, of course, but there was always something in me that wanted people to feel better and be healthier. That just comes from my heart. And so that's why I do what I do.
Thank you for doing what you do. Calvin?
I spent almost 2 decades at Kaiser Permanente, and I realized that the way healthcare was being delivered in America versus England or Europe for that matter, that in order to achieve the same outcomes that those countries are getting, that industry had to be part of that. So, the collaboration between industry, public health, and places like Kaiser and academics, I think is our way out of a big hole that we've dug for ourselves. And, I think the way that we solve problems in America has to be different because our infrastructure is different.
Thank you. Michelle?
I mean, I think public health is health equity. I mean, it's not divisible concepts, right? They are intricately tied. And so because of that, this is near and dear to my heart. I've worked in Baltimore inner city hospitals and have seen what health inequities look like. I've seen what systematic changes, a systematic bias that's been propagated against patients where certain options were not offered. I saw it with my own eyes. And so I only saw a microcosm. And so the commitment to trying to eradicate that at a system-wide level is important, and I'm very much committed to being a part of the solution.
Thank you. And so I want to just take a second. Thank you all for attending. Thank you for being here. Hopefully you have lots of great questions and you can follow up with all of our panelists. I want to thank our incredible panel for today. Thank you for your commitment and your time here. I want to thank Izzy for pulling us all together. Thank you very much. But I hope you've gotten something out of this discussion, and we'll be looking forward to hearing your questions later. Thank you.
This is great.
Calvin, what's up? We've literally never met in person. Crazy, right? Yeah. Yeah, thanks for doing that. It's really good. Got some content to do a blog around it, so yeah.
I wanted to talk to so we met with Michelle Prince, we have a pathway.
On the MQF stuff.
Not only that, but just the format. So oddly enough, they okayed outfits work racing to FDA.
Oh, nice.
So, and they all MLR approved. Because what the fear is that we just put a bunch of stuff internally and we decide to think it's MLR.
Yeah, start using it, yeah.
So we're going to for you and don't worry, you don't have to go with that.
Oh, yeah. No. Yeah, how to channel and maximize it. Cool. Sounds good. Yeah, I feel like there's just some areas that are getting like so strict on. I'm like, the one day I talked to Natasha, I was like, why am I even here then? Like literally, like they're like, we can't talk. Yeah. Exactly, yeah. Yeah, we need to merchandise it. It's already out there. Like, yeah. Is anyone from MDS on that? I know they've been doing a lot too. Okay, cool. Okay. Yep. Yeah, then I'll probably pull in Alyssa Pretlow from my team. She works really closely with Brian on the MDS side. Because I know it's like a lot of MDS impact. So just have another resource on it.
Is there someone that works in IDS? Because IDS has
Yeah, so it would be Mila, Sarah, still. Yeah, she's still covering that business. So
yeah, whatever you feel like.
yeah, maybe we pull in those two business units just for like, amplification and support of how it aligns from a product perspective. Yeah. You're here all day or? Nice. Is that Franklin Lakes or?
No, it's in Baltimore. We're going to experience.
Oh, okay. Yeah, I used to live in DC. You're telling me. It's also like an incredibly inconvenient place to fly to because you're like middle of nowhere, BWI. Yeah, they used to do not that it's any better, but they used to do the Alaska Air. Used to fly BWI to LA when I was in my 20s and made no money. That's how I used to get to LA. Sure, it's nice to meet you in person. Look forward to staying in touch.
Enough spots at the BD table for all the BD people, so it was like you gotta get there. It's a competition.
we still have it.
It's like, oh, there's a recession. I'm like, I wasn't really planning. I'm kind of too casual. Hi there.
I'm just gonna say, I'm gonna just like literally tap him on the shoulder.
So,
2 weeks in. 2 weeks in. That's 2 weeks ago.
So I flew through Tempe through Phoenix from North Carolina. So
there's no direct flight.
I think there was an
It
LAX
is.
direct.
Kids are sad or sad that
So you went to John May, Orange County.
Yeah, so I went to Phoenix. And then I went back out that way. Headed to Austin or somewhere. I'm supposed to go to Las Vegas next week, and I don't think I can make it. I'm too tired.
It's hard.
All of this.
I have to go coast to coast like often. It's coming back is fine, but going there is like.
Mm-hmm.
Yeah.
Well, this was hard. And I don't know if it's like age or number of days or what. Like, I came back and it was tough. But now it's like, when I so like I would go out to Utah, I was like the altitude. I remember having to
I think, yeah, you've got a human being inside you, so you gotta cut yourself a slack.
So my last
Oh, you should definitely.
yeah, because it was so that I didn't travel at all during my last one. I was just slight injury the entire pregnancy, and she was on time. All right,
So, ready?
I'm like, I'm gonna be permanent.
Let me do this. Okay. All right. Thanks.
You good?